Okay. Yes, hello, good afternoon. Greetings from Vienna. My name is Christoph Schukro. I'm a cardiologist from Vienna, the University Hospital, especially rhythmologist. And my co-chair, please.
Dr. Salim Al-Kabi. I'm an electrophysiologist from United Arab Emirates.
Good. And so, I would like to welcome you all to our first joint meeting between our two societies. And we will talking about Hope on the Horizon therapy of atrial fibrillation, old players and new stars, sorry. And so I think, Salim, you could start to present your first talk, please.
Okay, for sure. Do you see my slide? Okay, so my talk is about pulmonary vein ablation, which is the hard data in the clinical outcome. It's nothing to disclose. My objective from this talk is to demonstrate the latest evidence in rhythm control versus rate control and AFib management, to demonstrate the important concept in AFib management, and to demonstrate the recent evidence and the impact in the guidelines. So as we know, the AFib is a complex disease. It has a lot of genetics and comorbidities and environment contribute to the pathogenesis of this disease. And when the atrial fibrillation happens, it causes a lot of remodeling, electrical remodeling, leading to shortened atrial refractory period and contractility more remodeling, reducing the atrial contractility and set the stage for the thrombus formation. Also, there are structural remodeling, left atrium and left appendage become enlarged and decrease in the cardiac output. And the atrial fibrillation, it can cause heart failure, and the heart failure can also cause the atrial fibrillation. So the when you look to the atrial fibrillation, it can cause a neurohormonal effect, losing the atrial contractilities and atrial stress and fibrosis, high rate ventricle rate, and irregular left ventricle filling, which all these will contribute and lead to heart failure. And the heart failure, there are volume overload, LV dilatation, mitral dilatation, and this all will lead to atrial fibrillation and a progressive atrial fibrillation from paroxysmal to persistent. So it's a virtuous cycle between both, and sometimes you need to intervene to prevent the deterioration of heart failure. As we know, the atrial fibrillation is a progressive disease. It's a progress from paroxysmal atrial fibrillation to persistent and permanent, and usually that will lead to change the mechanism of the from trigger activity to functional reentry substrate and structural reentry substrate, which will lead to difficult to restore the sinus rhythm if you intervene late. And it's exactly like a malignancy. If you catch it's mimic the malignancy disease. If you catch it in the early stage and resect it and cure it, you are able to cure it. If you leave it until late stage, then it's difficult to treat. So the question is rhythm control is the right choice to manage the patient with atrial fibrillation? And if you go back to the 2022, the firm trial, it showed that there are no benefit in mortality between rate control and rhythm control. But in that study was the rhythm control done by antiarrhythmic medication. In the sub-analysis for that study, it found that the storing the sinus rhythm may be associated with decreased mortality. But because the the medication, the antiarrhythmic was used with their side effect and interaction with the warfarin, it maybe increase the mortality, and that's what that contract the benefit of sinus rhythm and leading. There are no significant difference between the two groups. So it may be that time, maybe we need that they looked to beyond the drug. We need another mechanism. And the pulmonary vein isolation had been reported the first time by Dr. Hessiger in 1998. Since that time, there have been a comparison study between the pulmonary vein ablation and the antiarrhythmic medication. And it showed that it's a safe and alternative to antiarrhythmic medication, especially if the patient failed one drug, because if he failed one drug, it's rarely that the second drug will be effective. And regardless what's the mechanism, if you look at the slide, is it cryoablation or radiofrequency ablation, the successful rate of storing the sinus rhythm is higher with the pulmonary vein ablation comparing to antiarrhythmic medication. And this has been consistent in a different study, and this is the meta-analysis. If you look to the blue bar, the ablation is more successful to have a free of AFib comparing to antiarrhythmic medication. And this is another meta-analysis which published recently in 2024, also showing that consistent that pulmonary vein ablation is more effective in keeping the patient's sinus rhythm and comparing to the antiarrhythmic medication. And also it have a psychological impact. If you look to this study is a randomized trial. It's 100 patients randomized to pulmonary vein ablation or medical therapy. And if you look to the yellow part is the ablation, the hospital anxiety and depression scoring scale, it showed much better in the patient with the ablation comparing to the antiarrhythmic medication, with the less also burden of AFib and less symptom severity. And the ablation also associated with the reduced rate of disease progression comparing to the drug. And the patient who receive ablation, usually they progress slowly comparing to pharmacological groups, and the rate which around 8.6 per year. We know that between the the types of AFib, the stroke and mortality risk in a patient with the resistant or permanent AFib is higher comparing to the paroxysmal. And this study have been shown the rate of stroke and mortality is less than the paroxysmal comparing to resistant. And this has been consistent also in the several study, which showed that the stroke and systemic embolism is more in the non-paroxysmal atrial fibrillation and also the mortality. So if the question is, if the catheter ablation reduce the progression of the atrial fibrillation, is there any reduce, and does it reduce the mortality? And the study Cabana, it failed to show difference in mortality between paroxysmal and resistant and long-standing, even though there was a trend toward the less mortality, but still showing that the decrease AFib recurrence and improve the quality of the life and all type of AFib, the paroxysmal, resistant, and long-standing. In the Cabana heart failure, which is a sub-analysis of the Cabana studies, it showed that the patient with the LV dysfunction, heart failure with the LV dysfunction, there was a significant lower primary endpoint in death and disability and stroke and serious bleeding in the ablation group comparing to antiarrhythmic drugs. And also it showed reduce all cause of mortality and also the recurrent of the AFib. And that was also consistent in Castle AFib. It showed also all death, cause of death is lower in the AFib ablation, catheter ablation comparing to the medical therapy with the antiarrhythmic, and also cardiovascular death and heart failure hospitalization. Also, there has improvement of ejection fraction in the AFib ablation, more significant comparing to medical therapy. And this is a study with a single center that showed looking to the end-stage heart failure. We're waiting for heart transplant or LVAD. And the patient who have an AFib and treated with the pulmonary vein ablation have less mortality, which is the heart transplant or implanting the LVAD. And this was consistent in the meta-analysis. It showed that patients who receive a pulmonary vein ablation have lower mortality, heart failure, hospitalization, and improvement in LV function and quality of life. And this is also was shown again in the recent meta-analysis that the ejection fraction is improved in a patient with and more in the catheter ablation, and the quality of life and the atrial fibrillation burden is more better in the catheter ablation comparing to medical therapy. Also, all mortality, cardiovascular death, and all mortality is better in the catheter ablation group. So, what about the heart failure with a preserved ejection fraction? Can you apply the same principle in the reduced ejection fraction? And the study showed also the primary endpoint is less in the ablation group comparing to medical therapy. And this is another study which looked to the patient. It's a small study. It's about 31 patients randomized to ablation or medical therapy. And they had a right side catheterization before and after. And it showed that the brain wedge pressure is better and less in ablation group comparing to the medical therapy. Also, the quality of life, and also the VO2 max and the heart failure symptoms. And also showing that in the 6-month follow-up in ablation group have less symptoms, and there are no heart failure symptoms comparing to medical therapy. There was no still most of the patients have the symptoms and the finding of heart failure by hemodynamic. With the recent also meta-analysis for all the study done in the preserved ejection fraction, they still show that they are a benefit in the cardiovascular death in favor of pulmonary vein ablation. So then the third question is, what's the best time to do ablation for? This is an observational data showed that the early referral is a better survivor and less event in the early referral comparing to the late referral. And this is also a recent publication. It showed also the observable data. Still, the early referral is better comparing to the late referral. There are a recent study also. It's a randomized multi-center, randomized about 100 patients in one group for one group to receive an ablation within a month, and a delay ablation is at the end of the 12 month. During that period, they get an optimization of medical therapy and modifying risk factor. And they look if there are any significant increase or difference in survival, and it showed there are no significant difference in survival in the early and delay group if it's not exceeding 1 year. And as we know, there are different modalities of the ablation is by cryo and currently also pulse field and RF. But what we know definitely, and they are reduce complication with time. If you look to this diagram on the left side, they are over the 10 years, there are a decrease in the rate of the complication. This is secondary to improvement of technology and also improvements in the skill. This evidence have been impacted in the guideline. This is the ACC guideline, and it showed that if a patient with failure of antiarrhythmic, they are class 1 indication to go for RF ablation. Also, symptomatic paroxysmal atrial fibrillation, to choose the catheter ablation as a first-line therapy is a class 1A. In the patient with the persistent whom are being managed with the rhythm control strategy, catheter ablation is first-line therapy is a class 2A. In the American guideline, the heart failure patient, patient with the heart failure with reduced ejection fraction and AFib, arrhythmia-induced cardiomyopathy should be suspected, and early and aggressive approach to atrial fibrillation rhythm control is recommended. If the patient in the maximum medical therapy, catheter ablation is beneficial to improve the symptoms, the quality of life, ventricular ejection fraction, and cardiovascular output in some special groups. Also, the patient with the preserved ejection fraction is reasonable to expecting benefit of catheter ablation can be used to improve the symptoms and improve the quality of life, and in class 2A. In the recent European guideline also, for a patient with the paroxysmal atrial fibrillation, first-line treatment, catheter ablation is beneficial, and also symptomatic persistent. If it fails antiarrhythmic, catheter ablation is beneficial. So, take-home message: AFib is a multifactorial disease in which controlling a risk factor is critical, and maintaining sinus rhythm has more and more evidence for superiorities. And in patients with heart failure, catheter ablation seems to be superior to antiarrhythmic, and maybe also gain in the reducing mortality and improving ejection fraction. Early referral for ablation is linked to better long-term result. And thank you.
Yeah. Do you hear me?
Yes.
Thank you very much, Salim, for your really detailed presentation. Really enjoyed it, especially the meta-analysis from September. I didn't know it yet. So I have no questions here in the chat or in the question section. So I think that we could continue with your presentation, Omar. And is it okay for you?
Yep.
Because
So
there's still no questions yet. So, okay, sorry. Okay.
So the next speaker will be Dr. Omar Al-Falasi, and he will be talking about the antiarrhythmic drugs versus pulmonary vein. Cannot see the, title. Pulmonary vein ablation, how to choose the right patient candidate.
Thank you very much, Salim. Let me share my screen. Thank you for the organizers for the invite. I do share some slides from Salim's talk. He was very thorough in his presentation. So I'll try and convince our audience today about the atrial fibrillation and the need for. Can you guys see my presentation? Yeah. So I'm sharing my slides now. Can you see it? So, because I see only my slides now. So,
It's not a presentation.
yeah.
It's,
So let's go. Our, okay. Yes.
So slideshow, Omar.
That's what I'm doing. Let me come out. For a second. Let me stop sharing and share again. Sorry. Just stop share entire screen. Yeah.
Now it's perfect. Thank you.
So the outline for my talk will be a quick introduction, some concepts which were shared by Salim initially, but I thought they were extremely important to share with anybody who's taking care of atrial fibrillation patients. The evidence for rhythm control, though to a much smaller degree compared to Salim, strategies, and our take-home messages. So atrial fibrillation, of course, as we all know, it's a supraventricular tachycardia characterized by uncoordinated atrial activation leading to atrial remodeling. Of course, Dr. Salim has mentioned the stages for atrial remodeling, including the electrical, contractile, and the structural remodeling, as well as the neurohormonal changes that are associated with atrial fibrillation and sustaining atrial fibrillation in the long run. So it's the most common sustained cardiac rhythm disturbance in adults. Of course, we all know the consequences of atrial fibrillation when it comes to thromboembolic events and the significant morbidity and mortality, as atrial fibrillation is a standalone risk factor for mortality in our patients. So atrial fibrillation is a very complex disease. As we can see, in the middle, we have the factors that impact atrial fibrillation. However, we can't actually modify them, being aging, ethnicity, male sex, and genetics. However, the bigger circle, we have a lot of modifiable risk factors that can impact the outcome of our patient with atrial fibrillation. So controlling these is actually of cardinal importance to achieving or having very good outcomes for our patient and improving their prognosis. Again, the progression of atrial fibrillation, and I've chosen like 3 colors. We want to see more of people in paroxysmal stage of atrial fibrillation, where it's still green and we can actually impact the outcome of our patient. And in some patients will have a significant improve in their prognosis and their quality of life, and the long-term amount of recurrence of atrial fibrillation they're gonna have, because we're targeting the triggers and we're treating them. And we want to see less of the red permanent group where there have been so much structural changes and so many reentrant circuits. And we can't actually control the atrial fibrillation anymore despite all efforts. So when we talk about the rhythm control, is it the right choice actually for our patients? And of course, I think one of the most important trials have been published when it comes to atrial fibrillation patients is the EAST AF-NET4, where they randomized more than 2,500 patients to early rhythm control. And I would like to underline the word early rhythm control compared to usual practice, in which patients they received rate control and standard of care. So the early rhythm control was actually treating these patients with medications and ablation. Up to almost 20% of patients received ablation. And early rhythm control was patients who were diagnosed within a year with atrial fibrillation. Of course, this was a major trial that showed actually hard outcome benefits for our patients, with a significant reduction of the primary endpoints as well as cardiovascular deaths and stroke. So a lot of people has been doubting the results from this trial, since Cabana, for example, didn't show the same results. However, I think the major points or the major differences between ESAF, NAT4, and the other studies was the time of intervention. And it goes back to the initial slide that we show, where we want to see more of the green patients who are still in the paroxysmal atrial fibrillation stage. Of course, by now, I think we have no doubt that if you want to achieve rhythm control, ablation is actually superior to medical therapy, and we'll go into details later. But here, almost 20% of patients underwent atrial fibrillation ablation within a year. And a major difference between this study and some other studies which were an intention to treat analysis studies, most patients actually remained in sinus rhythm in the intervention arm. So what are the strategies available for rhythm control? Of course, we can sustain the rhythm with medical therapy, as well as catheter ablation, and some more advanced techniques which are like surgical and hybrid techniques, but we'll focus more on the catheter ablation this talk. So when we look at the 2024 guidelines from the European Society of Cardiology, they split the patients into paroxysmal atrial fibrillation and persistent atrial fibrillation. Of course, the major factor in choosing your medical therapy here would be the presence or absence of structural heart disease. So if you have a patient who have heart failure with reduced ejection fraction, in whom the ejection fraction is less than 40%, then it's a class 1 to go to amiodarone. If you have moderately reduced ejection fraction patients, however, he has structural heart disease, then it's either amiodarone or dronedarone as a class 1, and it's sotalol as a class 2B. And the absence of structural heart disease with normal ejection fraction, then the patient can go to either dronedarone, flecainide, or propafenone as a class 1, of course, sotalol as a class 2B. And for the first time for the European guidelines, we actually do see the catheter ablation for the paroxysmal atrial fibrillation group as a class 1. It's a class 1A. And when we talk about persistent atrial fibrillation, I love their care AF pathway, meaning that they, for the patients with persistent atrial fibrillation, they actually ask you or allow you to go for an electrical cardioversion just to clarify the benefit from sinus rhythm, because some patients, they just adapt to having atrial fibrillation, and they're not actually realizing the amount of symptoms that they're actually having. In order for you to clarify this, you can actually do a trial of cardioversion, get these patients in normal sinus rhythm, and then start treating them and choose your treatment pathway, either to go for rate control or a rhythm control pathway. So the same principles apply again if you have structural heart disease and a patient persistent atrial fibrillation, and you chose to go for a rhythm control strategy. Then if the ejection fraction is below 40%, it's amiodarone as a class 1. If the ejection fraction is between 41 and 49%, with it's amiodarone and dronedarone and sotalol as a class 2B. And in the absence of structural heart disease and normal ejection fraction, it's again dronedarone, flecainide, propafenone, as well as sotalol. And again, we see here catheter ablation is sitting on the side as a class 2B in order to restore sinus rhythm and maintain it in these patients. So when we start looking beyond drugs and medical therapy, of course, we spoke about the Cabana trial. And even in the Cabana trial, we didn't show a significant difference at the endpoints. It actually did show that atrial fibrillation ablation is superior to medical therapy when it comes to maintaining patients in sinus rhythm. Because that was part of the analysis of the Cabana trial, and we can see that the benefit was really driven in patients who were symptomatic but who were young, below 65 years of age. The borderline benefit was up to 75 years of age, and doubtful benefit was beyond 75 years of age. Of course, even more recent evidence confirming the fact that ablation is superior to antiarrhythmic therapy. We're talking about early AF and progressive AF, where cryoablation was done compared to medical therapy. And again, we see the same graphs and the same Kaplan-Meier curves, with ablation being superior to antiarrhythmic medications. So we've had a lot of trials about atrial fibrillation ablation. And if we want to summarize some of these trials, is that we know they improve the clinical outcome. They improve reduce the stroke, the bleeding risk. They improve the heart failure hospitalization. Of course, they did improve heart failure and left ventricular ejection fraction, as was nicely demonstrated by Dr. Salim. They do lower the mortality when compared to medical therapy. Of course, as a first target, we're targeting pulmonary vein isolation, followed by maybe lines and cafes with much less stronger evidence. They improve symptoms and quality of life. The technology includes radiofrequency ablation, cryoablation, pulmonary and pulse field ablation. And it reduces an appropriately selected patient. It can actually eliminate the recurrences of atrial fibrillation. So who benefit most from the atrial fibrillation? We see on the graph on the left-hand side, people who would have a lower benefit of atrial fibrillation trial. These patients who are asymptomatic, we don't really know whether we're going to benefit these patients by doing atrial fibrillation ablation or no. People who are otherwise healthy, and people who have low atrial fibrillation burden. On the other end, we see people who would benefit from atrial fibrillation ablation. It's people who are symptomatic, have a lower quality of life. Of course, people with heart failure, especially people who have tachycardia-induced cardiomyopathy, and people with high atrial fibrillation burden. So we see in the guidelines, of course, atrial fibrillation ablation in people with paroxysmal atrial fibrillation is currently a class 1A indication. And I would need to add that they did mention, actually, if you do this within the initial 12 months, based on the evidence that was shown recently with the ESTF-NET trial and other trials, where the benefit is actually driven when we refer these patients for ablation early. It's still a class 2B indication when we're talking about patients with persistent atrial fibrillation. Of course, it's a class 1 for patients with heart failure, reduced ejection fraction. If it's a tachycardia-induced cardiomyopathy, and it's a class 2B for patients with heart failure. So techniques, of course, we have the cryo, the radiofrequency ablation, which are the thermal energy sources, and we have more recently the pulse field ablation, which is a non-thermal source of energy for ablation, which is by having a non-thermal impact is reducing the collateral damage on the non-cardiac or extracardiac tissue. So I think the key question is who is the ideal atrial fibrillation patient that we will refer for ablation therapy rather than controlling him with medical therapy only. Of course, we need to discuss with the patient. The patient needs to be willing for a rhythm control strategy by ablation. Very highly symptomatic patient, ideally patients below 75, even though I think by the pulse field ablation, I'm a bit more comfortable doing even elderly patients. And I think my colleagues in Europe are going to comment on this because they see more and more older patients for ablation therapy. And maybe we need to add the word virility of the patient rather than the age as a number. Of course, patients with paroxysmal atrial fibrillation definitely will benefit from the ablation therapy. As you mentioned earlier, if the patient has a tachycardia-induced cardiomyopathy, patients who have controlled risk factors, and this has been shown in many trials, like patient with uncontrolled risk factor, they don't do well with the atrial fibrillation ablation. They have recurrences because we haven't changed or we haven't suppress the trigger or the driver behind the atrial fibrillation development. Of course, patients who failed or didn't tolerate at least one antiarrhythmic drug, and patients who are still not in the stage of a significant structural change, meaning a severe left atrial dilatation. So my take-home messages on the atrial fibrillation ablation versus medical therapy is that atrial fibrillation is a multifactorial disease in which control risk factors is of cardinal importance. It will impact the outcomes of whatever strategy you are using. Rhythm control has more and more evidence for superiority compared to rate control. Catheter ablation is superior to antiarrhythmic drugs for maintaining normal sinus rhythm. And early referral for ablation is linked to a better long-term result. And I would quote Dr. Luigi De Biase when he says, when you have an AFib patient, intervene early and intervene early with ablation rather than with medical therapy. Thank you very much.
Thank you, Omar, for this nice presentation. Any question? I don't think we see.
Lucas had a question.
Presentation, Omar. But I would like to know how you handle anxiety, patients with atrial fibrillation, anxiety in the Emirates. I mean, we know that if you have more obese patients, like losing 10% of weight might be as successful as in PVI. Do you have a cutoff where you say, you should lose weight, or how do you handle it?
Honestly, as I mentioned earlier, like we do encourage patients to modify their risk factors. And very obese patients, I normally ask at least for 10% reduction of their weight before I commit them for atrial fibrillation ablation. So we do encourage patients. I would actually delay the procedure until I see a real commitment from the patient for the weight reduction.
Yeah, thank you. I think we do it the same way, and I think that's quite important. Thank you.
Oh, it's a very interesting thing that you said is that age is not only a number. because we had a few weeks before in Vienna a little symposium, and one of our colleagues said that he would make a cutoff at about these 75 years. And I think it's quite right what you said, that we have to take into account how fit the patients are instead of just looking at the number of his age. Yeah. Good. So I take a look again. There are still no questions from the audience. Okay, so I think we can go on. Thank you very much, Omar. And next speaker will be Lucas, but just let me look which one. Yeah, Lucas Fiedler from the Hospital of Wiener Neustadt. So just give me a second. So, and yeah, Lucas, you will present a talk about ablation techniques in atrial fibrillation.
Hello, a warm welcome from Austria. Thank you very much for the invitation to give this talk, and I'm very happy to be part of this first session together with the colleagues from the Emirates. My talk is choose the right intervention path, ablation techniques of atrial fibrillation. We've heard a lot about the background of atrial fibrillation, and I want to just remind you that to target these patients early, as we heard in the previous talks, is therefore important, because atrial fibrillation about over reduced left ventricular function and atrial stretch begets atrial fibrillation. And that is what we should tackle even in medication or with catheter ablation. We all know that the triggers come from the pulmonary veins, and it's clear to say that the more AF happens in those patients, the more it begets to substrate in the atrias, so that atrial fibrillation can be persisted, and that's what we want to break. I also agree that we have to talk to these patients in advance, and we know from these studies, when we look at about the weight loss on those patients, we really have better outcome for this patient in this consistent training groups that they have after procedure, lower recurrences. So we have to really work on all the side effects, even on sleep apnea in patients, where we see that is in this hypnogram, patients who have atrial fibrillation and get the CPAP mask on, immediately they convert into sinus rhythm and the heart rate stabilizes. So we have already seen this picture. The cornerstone of atrial fibrillation ablation is still PVI. And whatever source or whatever energy you use, you have to be sure that you have a consistent lesion to get rid of these triggers of the pulmonary veins. We know it does not matter if you do it with RF energy or if you do it with cryo. In this older paper, it's important to be consistent in these lesions. And in this newer paper, we can see that if you want to really tackle those problems, you have to look very exactly. So you have to look for atrial fibrillation after ablation, because you might miss something if you don't do a stringent monitoring in these patients. But if we do that, we have the chance about 80% of people in the first 2 years to keep them off atrial fibrillation. We know that in persistent atrial fibrillation, the results are still poor. If you do it a single procedure or multi-procedure in this really old paper, you see it falls down and you have to be more consistent in this patient. But we do not really know what is the right path to do in those patients. So you all are familiar with this New England Journal paper, where they tried to get more information about what to do in those patients. Is pulmonary vein isolation enough, or do we have to do some sort of substrate modification or additional lines? And as we know from this paper, it does not matter what you do. You have to do a consistent pulmonary vein isolation, whatever you do in advance. We know from this time on does not change the game a lot. But what do Europeans do in all these papers? In this paper from Nikos Dagres from Leipzig, he asked in this questionnaire, what do people do? And you see, it's a big potpourri of almost everything they do. Cornerstone still is the PVI, but in persistent atrial fibrillation, even in long-standing persistent atrial fibrillation, you are kind of prone to do something else to do this, to help these patients. If it is the stepwise approach from the Bordeaux group, or if it is cafe ablation or substrate ablation, you have the feeling you have to do some additional thing to do this patient. Still, we don't know if this is helpful. So I'm very proud to present this paper you might be familiar with. We had the opportunity to work with Jan Hu and Christopher Piokowski to kind of ask the same question once more, if there is something to get out of additional ablation lines in those patients. We randomized 324 patients to PVI only versus PVI plus substrate modification. And we had the luck to observe all these patients by 73%. So it's a very robust recurrence rate we can present. PVI only was 55% went PVI only, and 40% about went to PVI and substrate modification. And what we saw in those patients, we saw a big potpourri of substrate. It could be more likely to be on the posterior wall. It was also at the septum. So we were thinking a patient-tailored approach to address the additional substrate in advance to pulmonary vein isolation might be beneficial in those patients. What were the results? The results showed, at least in our observation, that a tailored-based approach to the substrate was significantly better than just doing PVI alone. And what we are very proud of is that the implantable cardiac monitors were present in a lot of patients. When you do substrate modification, which is kind of the Leipzig school to do it, it's important to use high-density mapping catheters. This is an example of one observation with high-density mapping catheters. From my point of view, it does not matter with which company you use, but if you want to kind of get of a good information about substrate modification, you have to be consistent. From my point of view, nowadays, you should use high-density mapping catheters to get a real information about the substrate of the patient. And when we look, how good are we in doing pulmonary vein isolations? We know on a very long term success, this is 16 years, in paroxysmal atrial fibrillation, we are kind of pretty good. In persistent atrial fibrillation, we are kind of acceptable. We are working on it to get these problems done better. But in long-standing persistence, the outcomes are pretty poor. After 2 years, more than half of the patients are again in atrial fibrillation if you do a single procedure. So there's a new kid off the block. My previous speaker already mentioned this, PFA ablation. And does this change anything in our kind of thinking about atrial fibrillation? Yes, we know that there are reduced complications, and it's easy to use, and it's easy to administer, so the learning curve is pretty fast. But what we see, there is no big difference. Cornerstone PVI should be done in a very good way, then you have good results. But what we see is that procedure time itself is shorter. And in skilled hands, procedure time of 30 to 40 minutes is reasonable. And in other single shot devices, you might need a little bit more time because of, in this case, cryopollone administration. You need more freezing time, and the preparation of the balloon in between takes a longer time. Fluoroscopy time is the same. When we talk about pulsed field ablation, it is known that we do not want to destroy the integrity of the cell. We just want to make it not electrical active anymore, which by creating a porous formation in these cells to get rid of the function of these cells. What do we expect? And this might be some information. How should we in the future organize our EP laboratories? We see this this data from Tobias Reiklin from Switzerland, that over the time RF ablation was still increasing because he treated more and more patients. Cryoballoon kind of took over a little bit more in the single shot devices, but it's clear that in the future we will see more and more PFA ablation. From my point of view, in this very fast ablation strategy, this is what the EP laboratories, at least in Europe, would need to treat more patients with this endemic disease. So in my conclusion, I have to say, yes, we have to look at the risk factors first. In Europe, we do not treat patients who don't take their pills, who are not eager to get rid of almost every risk factors they have. The first strategy, also in persistent AF in our lab, is pulmonary vein isolation, and try to address the pulmonary veins as hard as possible so that the conduction there is gone. And in the future, I think PFA will be more and more used in times of the time because it's not that time consuming. In persistent AF, I think a tailored approach is a very good choice to make, but use high density mapping catheters to really get an idea where the substrate is. Test all the lesions. Don't do lesions and don't test them. You have to kind of get a bidirectional block in every lesion you do, even if you do a box isolation or a septal line. And I think that ablation shows a real advance in chronic heart failure. These are the patients we have to address especially, and this is why I think that we have to use faster ablation approaches to not have too long waiting list time for those patients who need it and where we know that the mortality is increased if we don't treat them. Thank you very much.
Yeah, thank you very much, Lucas, for this well-elaborated talk. Actually, we had a first question, but I think that we should discuss it then at the end. And so I would like that we continue with the next talk. We go some 100 kilometers more to the west, and I'd like to present Lukas Mottloch from Salzburg-Entwicklung. And Lucas, you will give us a talk about closing the gap knowledge insights into the pathophysiology of atrial fibrillation. Please, Lucas.
Thank you very much. Thank you very much for having me here. Does everybody, wait a moment. Does everybody see my screen?
Yes, now it's
okay, great. So thank you guys. Wait, I have to get this done. So thank you guys for having this talk, and it is really a great opportunity to find our both societies together in the first meeting, which is first collaborative meeting, and I heard it's a great success. We have over 400 participants, so thank you for the organizers. This is great. And actually, so I live in Salzburg, and I'm head of a professor of cardiology, and I work in hospital, which is a very nice area near the mountains and the lakes. And I think we both have something together. You see, we have just the white with the snow, and you have the sand, which is also one color. So I think the cooperation, we are looking forward with you guys. So I have nothing to declare. And I would talk about the basics. First of all, we heard so much about atrial fibrillation, by why atrial fibrillation matters. This is a typical way, lifespan of an Austrian. You see, you are very fit at the beginning and you start to be more and more fragile. And probably then is a point where you get to atrial fibrillation. I think Arnold Schwarzenegger has it already. And as the prevalence is increasing, we know it, atrial fibrillation worldwide, especially in industry countries, and we see the patients are older and older. And we've already seen that slide. We see it's not the aging, it's genetics, it's may sex, but we have lots of these comorbidities. And we know that comorbidities, they do induce cardiac remodeling. And that might be one of the most important reasons why we see it, especially in aged patients, and why the prevalence, the incidence is going up. So general concept of arrhythmia, why to study it, or why, to know it. Maybe this fun slide. I mean, if you like the cardiac cells, you might feel like a medical student. But on the other hand, I think you understand better patient's history, laboratory, and radiology. So first, let's go back to the heart tissue level. This is not the atrium, but this is minor. This was a picture of my laboratory. These are from operated patient heart, healthy heart tissue. And these are guys who had orthocardiac remodeling, for example, aortic stenosis. And you will see the blue strains, this is fibrosis. This is kind of quite a hard remodeled heart. And what you find in the atria, but also in the ventricle, is first you get hypertrophy from the myocardiocytes, and you will get more and more fibrosis, and you will find dead guys, microfibroblasts. What the issue with that one? So, I mean, I'm a big fan of the movie, and we know the Anakin Skywalker was not bad at all. He involved with the dark side, and I think the dark side of the tissue in the heart is the myofibroblast. This is a bad guy who is actually the Darth Vader in the heart, and he is really pro-arrhythmogenic. And so what happens? We have first at the beginning of cardiac remodeling, we have the fibroblast who is developing through all pathologic structures like, for example, atrial stretch and inflammation into the myofibroblast, who is very pro-arrhythmogenic. And this is the cardiac remodeling. This is a theme of cardiac remodeling you guys familiar with. So we have the healthy heart. We get time of the stressor, inflammation, arterial hypertension. We'll have more inflammation, cardiac death, and you will have more and more myocardioblasts, myofibroblasts, which refers goes with heart hypertrophy, and we have more fibrotic tissue. And why is it bad? So we have an interaction between myofibroblasts and cardiomyocytes in the diseased heart. And especially this is a paracrine interaction, this is a cell-cell interaction. Actually, this guy is talking to the cardiomyocytes, and it's really introducing a change in cardiac electrophysiology with a kind of pathogenic and involves arrhythmias. I also try to explain it to my other residents. It's like the bad friend next to you. He tells you something bad, and he gives you the spark, and it comes as the explosion, a disease, heart, and cardiac arrhythmias. So this is one of the most, I think, important basic how we get arrhythmias in the heart. And mechanism of cardiac remodeling in the atria. Actually, the most important mechanism is atrial stretch. And all the diseases which produce or induce cardiac atrial fibrillations are diseases which gives you atrial stretch. You have heart failure, you have atrial hypertension, you have valvular disease, and this is all giving you higher pressure in the atria, induce atrial stretch. And if you have atrial stretch, you will find a bigger atrium, you will find a reduced compliance. You also find an increase in epicardial tissue, which is also important because also the adipocytes are talking to cardiomyocytes and changing the electrophysiology. On the other hand, of course, fibrosis with the induction of myofibroblasts, more inflammation, and this gives you actually atrial fibrillation. So this is a basic pathophysiological mechanism in atrial remodeling. So this is first with atrial stretch come myocytes hypertrophy, it comes death, inflammation, fibrosis, and this will give you a very pathologic remodeling of the arterial tissue. So let's go back to arrhythmia mechanisms. Why is all the atrial remodeling and developing on the changing electrophysiology very important for induction of atrial fibrillation? If you go to the very back to the basics, arrhythmia mechanisms, first you need a trigger. And we know three main triggers. This is first increased atomicity. So it means you have a development of pacemaker cells, which give you a trigger. probably most of the time in extrasystole. On the other hand, calcium is very important. So you have calcium gives you delayed and early after delaporization of the action potential. Delayed means, so calcium triggers are coming during the vulnerable phase of the action potential part, which is phase 3, or on the early phase. So it's all calcium overload, it gives you a trigger and the arrhythmia is starting. And indeed, if you look inside the pulmonary veins, into these pulmonary veins, this is like a study from 2004, you will find all these mechanisms, increased automaticity, and early and delayed pulmonary veins in the diseased pulmonary veins for stretched hearts, for stretched atria. And on the other hand, what's very important, you don't need only the trigger, you need the interaction of the trigger and the pathological substrate, which keeps the arrhythmia alive. So in a normal heart, if you got an extrasystole, which is caused by one of the trigger activity, it will cause you nothing. But in the disease atria, if you have a substrate which takes the, which will keep the arrhythmia alive, and for that, one of the most important mechanisms is slowing of the electrical conduction. So basically, what are the mechanisms of arrhythmia of conduction slowing? It's first gap junctions. We know the cardiomyocytes interact with each other by gap junctions. And in a disease heart, you will find reduced expression. You will find also altered phosphorylation, also lateralization. On the other hand, it's reduced excitability. This depends very on the sodium channels. The phase 0 of the action potential is getting slow, is getting flatter, which means the excitability is propagating much slower. And what we talk about is fibrosis. This is one of the main pathophysiological changes, because fibrosis not even changes the electrical potential of the cardiomyocytes and the cardiac tissue, but also is a physiological, also makes pathological barrier of propagation of the cardiac excitability. So arrhythmia mechanism triggers. So on the other hand, to put it together, when we go back to cardiac physiology, is like, first, we have alterations in the action potential. We have increased excitability, which also goes with a pathologic cardiac repolarization. And on the other hand, we have slowing of the cardiac velocity. And when you go really back to the basic, to the theories, how arrhythmias are propagating into reentry, which is actually the pathology of keeping an arrhythmia alive, you will find the theory of the cardiac wavelength. So basically, if the wavelength, the cardiac wavelength is the time which a cardiac electrical signal needs to go from one place to another, normally in circles. And if the cardiac wavelength is shorter than the distance it has to go, it might produce re-entry mechanism because it meets excitable tissue and it goes on. And there are two things which influence the cardiac wavelength. First, it is the peak of the cardiac wavelength. So if you slow conduction, of course, you will get more arrhythmias. On the other hand, if you prolong the refractory period, you have a less probability of arrhythmia. This is, for example, the reason why amiodarone is working by blocking potassium channels. On the other hand, when you reduce the peak, you will go to slower conduction. That's why we found out during the time that class 1 antiarrhythmic sodium class blockers are pro-arrhythmogenic. So, and why the pulmonary veins? Why is it all happening in the pulmonary veins? I mean, we know that the border regions, especially, it's like in the world. If you have border regions, you have conflicts. And it's also what is happening in the heart. If you have border regions, you have fibrotic tissue, then you have myofibroblasts, which are interacting with the myocardium, which I already explained, and they gives you pathological substrate. And actually, that is also what the pulmonary veins are in the atria. They are kind of border tissue between the vein and between the myocardium from the atria. And if you look at the atrial remodeling, what's happening in the pulmonary vein, you will find more and more conduction barriers by fibrosis and more myofibroblasts here. And this is a diseased pulmonary vein. You will remember the first picture, what I showed you about like the diseased ventricle. The same you will see in the pulmonary vein. You find more fibrosis, more fibroblasts, more interaction. This will give you a conduction swelling, slowing, more triggers. And what's also happening is, this is a very old paper, but it shows that actually the fibers in the pulmonary veins, the structure is really changing due arterial stretch. So this is a very nice picture. You will find that fibers in the pulmonary veins of the disease atriums are poorly coupled to the left atria. They go in different directions. You will find more fibrotic tissue between it, and you have abrupt changes in the fiber, orientation prompting. That gives you triggers, and this gives you also a substrate which conduction slowing, which keeps reentries alive, and is affecting the left atrium, which this ends in atrial fibrillation. And the mechanism we shouldn't forget when we're talking about atrial fibrillation is also the autonomic nervous tissue. And we know we have the parasympathicus and the sympathicus, which is affecting heart rates and conduction, and also like conduction, electrical conduction. And we know that adrenergic, or by also cholinergic activation, will give you more arrhythmia triggers, what we already talk about, atomicity early and late after depolarization. On the other hand, it will also affect cardiopulmonary baroreceptors and also atrial stretch and give you more remodeling. So we have, on the other hand, we have all the diseases, but we have also the autonomic nervous system, which is important. And please don't look at that. This is really complicated. I found it from a paper, and you see that slide. You will see that's really complicated to understand atrial fibrillation. And I mean, how can we handle this complex disease? I think I'm thinking too much before you act, so just act. And I think pulmonary vein isolation, what we're doing is something we always had in history. If you looked at the Roman Empire, it was a very well-organized empire. On the border, you had chaos, you had barbarians. And what did the Romans do to keep them out from the empire? They built walls. Like in the northern Germany, like in Germany, they built the limes made by wood. In northern England, they built the Hadrian's wall, or made by stone. And what do we do with the chaos? We've heard about it. We do the same. So we doing our catheter ablation, we're creating borders lines, we're getting loss of the triggers, but we're also doing a line, which is kind of a wall, and we keep the chaos inside the pulmonary veins, because this is where the triggers are coming from, as I already explained. So this is a success we've already heard about. And also don't forget it, we know the new, the ESC 2024 guidelines, it's more about care. So we know that the first thing is, we've heard about it, look at the comorbidity, look at the comorbidity risk factors, because that's the risk factors which gives you an increase in atrial stretch, gives you increase in arterial remodeling, and then this all triggers like atrial hypertension, diabetes, heart failure. You also change the electrical substrate by inducing cardiac remodeling, myofibroblasts. So try to get, if you want to control your patient, try to reduce atrial stretch by getting rid of the comorbidities, and do a catheter ablation of heart, because it's also better than the pharmacologicals intervene. So I hope it was not too complicated to go back to the basics. Thank you very much. That's Salzburg, actually. That's where we are from the Austrian Cardiac Society. We hold our meetings at Salzburg in the summer every year. We have great lakes. We have mountains who love the hearts. And we have a winter with a very nice region. This is the Kitzsteinhort, which is one of the glaciers in Austria. We have snow all over the year, about 3,000 meters. And wait a minute. And I say thank you to everybody. Vielen Dank and shukran. I hope this is right in Arabic. And thank you. I'm ready for questions. Wait a moment.
Thank you, Lucas.
Thank you, guys.
Thank you very much for this excellent explanations of these complex mechanisms. And I would say, when we're looking at your talk, it's quite interesting that we are, I would say, such as naive to think that it's so easy to fight our enemy with such simple methods like PVI ablation. I asked Professor De Potter to present his talk directly so that we can discuss all the different presentations at the end. So Please, yeah. Please, Professor De Potte, your talk about pulsed field ablation.
Hello, everybody. Sorry about that. I think you can now see my screen.
Yes, it's working.
Fantastic. Thank you very much, dear chairs. Thank you very much to J&J and particularly to the organizers of this meeting to allow me to share our experiences with pulsed field ablation with the UAE community. These are the relevant disclosures for this particular presentation. And as we just heard from the previous presentations, what we are trying to achieve is not new. What we're trying to do is a treatment strategy that has existed now for 30 years, which is PV isolation. We're trying to prevent triggers from the pulmonary vein to initiate atrial fibrillation. And the reason many of us are so enthusiastic about pulsed field ablation is very easy to demonstrate in a very simple video that takes a few seconds. What you see here is a circular mapping catheter in a pulmonary vein showing PV potentials. And what you will see now is the effect of a single pulsed field application. And it eliminates the near field PV potential. This is true single shot ablation of a pulmonary vein. Single shot ablation in itself is not necessarily new. We have had single shot ablation and we have had very efficient, very powerful ablation strategies for a long time. For example, think of HIFU, high intensity focused ultrasound, where we could measure time to isolation in milliseconds. The fact we have single shot ablation is not new. What is new is that the old technologies we had were usually limited in terms of mapping and power titration, but the main disadvantage of the historical techniques we had available for powerful single shot was that they were dangerous. All of these technologies, including HIFU, were taken off the market again because of unacceptable safety risks. And this is the breakthrough, of course, of pulsed field ablation. The breakthrough of pulsed field ablation is that it is non-thermal ablation energy, meaning that pulsed field ablation can destroy cell membranes, can destroy myocytes without relying on thermal effects, and therefore without causing collateral damage. It means concerns for damaging the esophagus, for example, no longer exist with pulsed field ablation. Concerns for damaging the phrenic nerve no longer exist with pulsed field ablation. The technology is therefore also sometimes called tissue selective ablation because it seems to preferentially or selectively ablate myocytes and spare the surrounding tissue around the heart. What I'd like to share with you in the next 20-25 minutes of this talk is our experience with one particular implementation, which is the J&J implementation of pulsed field ablation inside the 3D mapping platform that we all know, inside the CARTO mapping platform. So what has been developed is a novel generator and a novel catheter platform. You can see it here on the bottom right, a circular loop mapping catheter, 10 electrodes, variable loop, 25 to 35 millimeters variable loop that allows delivery of this energy. I'm not going to spend a lot of time on the preclinical data, but I want to highlight that also with this platform, as for other PFA platforms, it has been proven, it has been documented that this energy source is safe with respect to surrounding structures. There is no damage to the esophagus, no damage to the phrenic nerve, no PV stenosis. There is no damage to the surrounding tissue, and the tissue architecture is preserved, meaning we selectively destroy myocytes without harming surrounding tissue. In a little bit more detail, animal studies have confirmed that if we do ablation on purpose above the levels where we normally do ablation at supratherapeutic doses on the phrenic nerve, we are unable to damage the phrenic nerve despite trying. Same story for the esophagus. supratherapeutic energy delivery to the esophagus, directly over the esophagus, unable to show any damage to the esophagus. Same story for PV dimensions, no evidence, no sign of PV narrowing after post-field energy delivery. And the other thing we learned from animal studies, besides confirmation of the safety aspect, is optimal dose strategies. What you can see on this slide is that depending on the energy you give, whether you give a low or, and this is in terms of volts delivered, in terms of kilovolts delivered, low, nominal, high energy, and on how many applications you give, you can see that immediately after the application, there is a dose response. You can do a little bit ablation, but you can also do too much ablation. As you can see here on the bottom right, the effect of extensive energy delivery is probably not desirable. At some point, we are destroying too much atrial tissue, and this goes beyond the goal of the treatment strategy. This goes beyond PV isolation. And the result of this is that for this specific catheter and this specific generator and this specific PFA platform, the optimal dosing strategy is to deliver 3 PFA pulses through the catheter. 3 PFA pulses because it results in transmural lesions in all atrial targets without causing excessive damage to peripheral myocytes in the rest of the left atrium, which could, for example, lead to atrial tachycardias. The result of this is a very standardized workflow, which you see here in this animation, where we recommend to deliver 3 applications in a single position. This is automatic. Then rotate the catheter and again deliver 3 applications. Why rotate? To maximize overlap and to maximize the probability of PV isolation. The waiting time between applications is for safety reasons, is an observation we made in the human studies. The waiting time is 10 seconds between energy delivery, and this is done automatically in the generator. You don't have to do anything. You simply press start. The generator will give 3 pulses, wait 10 seconds in between every pulse, then you rotate the catheter and you deliver 3 more pulses. So as you have just seen now in this animation, we have ablated 1 PV ostium and 1 PV atrium with this strategy. The clinical results we've presented and published with this strategy have been reported for about 3 years now. The earliest experiences were collected in 2020 when we did the first human procedure, August 2020 in our lab, and we presented the early clinical outcomes 1 year later at the ESC 2021 meeting, where we reported on the safety outcome of what was called the Wave 1 cohort. Wave 1 in the clinical study of this technology, which is called the INSPIRE study, had a specific pre-specified subset of patients, 40 patients, in which additional investigations were performed, endoscopy, MRI scanning before and after, CT scanning, to confirm absence of unwanted side effects, to confirm absence of esophageal lesions, to confirm absence of PV stenosis. And what you can see in our report is that indeed in this very early subgroup analysis, 0 primary adverse events were reported, 0 esophageal thermal lesions were reported. In the entire study cohort of in total 226 patients, 0 clinical adverse events were reported, and the INSPIRE study was stopped prematurely because of this, because it was obvious that the trial would meet its effectiveness endpoint without concern for adverse effects. As mentioned, the trial also included assessment for PV stenosis and brain imaging. We did see, as we see with many PFA technologies, silent cerebral lesions on MRI scanning, especially in the very early experience of the workflow, after which we changed the study protocol a little bit, and after which we saw a spectacular decrease of silent cerebral lesions. All of these lesions resolved at follow-up none of these lesions led to any clinically observable phenomena. And what I'd like to do next is show you a bit how this looks like in practice. This is a first example of workflow. One of the unique aspects, of course, of this catheter is that it is integrated in the 3D mapping platform and therefore is capable of making a geometry and doing the ablation with the same catheter. This means we can design extremely simplified, extremely lean workflows. What you see here is an example of what I think is the maximum achievable lean workflow, which is one femoral puncture, one transeptal puncture, one sheet, one catheter. Very simple map. We took 1 minute to make this map. It took us 6 minutes to get access. Total procedure time, skin to skin procedure time, 23 minutes. Here again, you see the typical effect of one PF application, near field PV potential, PF application, elimination of the near field potential. And next, I'd like to show you in practice. So this is a video we recorded for a live case of the technology. You can see here the catheter itself. You can see that the loop is variable, as discussed already, 25 to 35 millimeters. It has a handle to steer. It is bidirectional. And we also use a steerable sheet, typically the Visigo sheet, to fine-tune the positioning of the catheter. This is what the catheter looks like on the X-ray in the heart. You can see that the electrodes are relatively big. This is important to remember when we look at the EGMs later. The far field will be relatively big because the electrodes are big, but you will see that the near field is eliminated with every application. And here we will do a first application in the LSPV. So here on the right top, you see the template of the PV potential, sharp high frequency component. And you see one PF application. And again, you see complete elimination of the near field component. There is a relatively big residual far field, but as mentioned, this is due to the fact that the electrodes are relatively big. It means nothing. We do 3 applications, rotate as the movie I showed you, 3 more applications, then go to Atrial. And the other thing I'd like to show in this video is the effect we typically see on the right side when we do application on the RSPV. We almost universally see phrenic nerve capture. We almost universally see contraction of, we almost always, there shouldn't be audio in this video. I hope you're not hearing it, but you almost always, you just saw it here, you almost always see the diaphragm contracting. And we have seen this in every single application on the right side. We have never, and there is not a single patient in the INSPIRE study where we have seen phrenic nerve paralysis or loss of function, confirming safety of the PF delivery with respect to the phrenic nerve. The clinical outcome we published last year with PF ablation in the integrated carto mapping system is shown here on this slide, is slightly below 80% clinical outcome defined as 12-month freedom from any symptomatic atrial arrhythmias. And what you can further see in a sub-analysis that we have published this year is that the strongest predictor of successful ablation is sticking to the standard recipe. What we have seen very clearly in our data set is that those patients that received the planned number of applications, 48 applications per patient or 12 applications per vein, remember 3 applications osteal, rotate, 3 more applications, go antral, 3 applications, rotate, 3 more applications. So that's 12 per vein or 48 in total if you have if you have a normal anatomy of 4 veins. Those patients that received this recipe, let's call it, were far more likely to be clinically successful than the patients that received fewer ablations. Comparing the INSPIRE results to other published PFA data is shown here on this slide. On the left half of the slide, you can see INSPIRE data, compared to other PFA studies, such as Pulsed AF with the PVAC design, the Pulse Select design, or the Sphere 9 study, or the Farapulse studies, you can see that they're all very similar. And I think we should also remember that on the left, RF ablation still has the best reported outcomes we have seen so far. PF ablation has met but not exceeded historical RF clinical efficacy. And if we compare the results of Inspire on the right to what is reported in registries, we need to look at standard of care rhythm monitoring, not at protocol mandated rhythm monitoring, because of course, the harder you look, the more arrhythmias you find. And if we look at standard of care rhythm monitoring, you see that the Inspire results compare quite favorably to published registries. Finally, I would like to spend a few minutes on one of the unique and nice aspects of integrated pulsed field ablation in a 3D mapping system, which is, of course, that we can do cases with very limited or even zero fluoroscopy, as we have seen in the ongoing experience. This is data from the US Admire study, and I'll show you in a second what we do in daily practice today. And you can see that early on it was observed that it is quite feasible in the Admire trial. In half of the patients in the pilot fail phase, procedures were performed without any fluoroscopy at all. And another unique element of integration in the carto mapping system, which enables this zero radiation workflow, is of course integration with intracardiac ultrasound. Intracardiac ultrasound in general is very nice technology. It allows you to assess visual contact and stability, and it needs no radiation. But specifically for integration in the mapping system, there is an implementation called SoundFam, which allows you to make a 3D model of the left atrium that is derived from echo images and is created using a deep learning model. It requires no human intervention. It looks like this. So what I am doing here is simply rotating the intracardiac ultrasound probe. It's a little bit accelerated, but the process takes 1 or 2 minutes. I rotate the probe. Nobody manipulates anything. Nobody needs any understanding of what is going on. We just acquire frames. And then the system makes this 3D model, which is immediately, of course, ready to start ablation. It has 4 veins. It will segment the veins. It will label the veins. It will cut away the appendage, as you will see in the next slide. So the appendage is automatically cut out, and we can put our ablation catheter in the target structures, the pulmonary veins, and start the ablation immediately. This is what you see on this example, on this image. And the other interesting element you see on this image is that tissue proximity has been implemented in future versions of the platform, which are available to us now. We did not have those at the time of the Inspire trial, but today we have contact assessment using tissue proximity, which you know from the diagnostic mapping catheters, of course, which indicates which electrodes are in contact. And this is important because with pulsed field ablation, if you do the application, the EGMs are gone. But if you do the application and you're not touching the tissue, the EGMs will be gone, but most likely they will come back. We know from remapping studies, PFA is not perfect. There is PV reconnection. And despite everybody in the field 5 years ago thinking that contact was not important for PFA, we understand now contact is more important than ever. So I think the points we can discuss later is workflow related. We use GA for all our patients. Deep sedation is possible. There is about 20% of the Inspire trial population that underwent procedures under deep sedation. As mentioned, there is phrenic nerve capture in almost every application for the right side. And there is sometimes vagal response. Well, not sometimes, it's actually quite common. When you ablate on the left-sided pulmonary veins, which you can mitigate by pacing or by giving atropine if you want to in deep sedation workflows. In GA, it's typically not a problem. And as shown, the procedure times can be extremely short, which means you need to start focusing on your turnaround times. The catheter itself is more bulky than a diagnostic lasso. It needs a little bit of specific training, which exists. There is in vitro simulation. There is a very nice simulator to help you understand what the position of the shaft does. The shaft is eccentric, so it means that if you rotate, the plane of the catheter sometimes changes, and you need to understand this. And of course, the 3D mapping system will help you. And one of the very nice things of PFA in general, of course, is that you can put it really nicely in the vein in an ostial position where we would never deliver RF energy, but with pulsed field, it is not a safety concern. And of course, stability and contact are guaranteed if you put the catheter in the vein. In conclusion, I think point by point, RF ablation is still the gold standard we need to beat. As I've shown you, the clinical outcome is a bit above 80% single procedure of drugs. We published actually in the Powder AF study, if you keep patients on drugs, you will see 98% success rate. So I think this is the standard we still need to beat, and PFA ablation, in terms of efficacy, has met but not exceeded this expectation. And RF ablation allows very high efficacy workflows. But I hope I've convinced you that pulsed field ablation has emerged as a very fast, very efficient, and potentially very safe ablation technology without any concern of damage to the esophagus and the phrenic nerve. There may be problems near the coronary arteries. There is an issue of spasm, which is poorly understood, and with the variable loop catheter, to be honest, also poorly studied because few procedures were done outside of the pulmonary veins. And we do not know yet what the lack of effect on the autonomous nervous system will do. But what is clear to me is that there is a synergy with 3D mapping. The assessment of contact is essential, and tissue proximity indication is a big step forward in this respect. And of course, the workflows we've developed, we can keep using them. It's simply changing the catheter and changing the energy, but we can keep our existing workflows, which is very nice for us to have. So thank you all for listening. I hope we can have a nice discussion.
Thank you very much for this really excellent and detailed talk about PFA. So if it's okay for you, I would start to present questions from the audience. We have two from Linz, actually the city where our new president of the European Heart Rhythm Association is coming from. So the first question is, considering the ESC guidelines, there's missing a word now, endorse primary catheter ablation in patients with paroxysmal AF. So what is the proportion of your patients with paroxysmal AF who go directly to catheter ablation, so without prior arrhythmic drug therapy? Actually, the question to all our presenters. Salim, we don't hear you.
For me, I know what I do is if the patient does not have risk factor like hypertension, obesity that I need to treat, I offer him directly AFib ablation. If they are a risk factor like obesities, hypertension, other comorbidities, or sleep apnea, while managing this and controlling it, I use antiarrhythmic if they are very frequent episode.
But in fact, how fast do you get an AF ablation in, for instance, in Belgium or in the United Emirates? Because what I know in Austria, most of the time you wait almost everywhere several months to get a PVI.
In UAE, we usually around a month is you could have an AFib. Yeah, 1 month.
Okay.
Yeah, if I can, I want to add to that comment that, first of all, I very much like the approach. I think I do the same in the absence of major comorbidities. And to be clear, we are talking about symptomatic patients, patients that get referred for symptomatic AFib. I offer 100% of them first-line ablation without antiarrhythmic drugs. And I think about 90% accepts, maybe 10% chooses to try antiarrhythmic drug therapy first. And with respect to the waiting time, our experience is a bit the same. Normal waiting time is 4 to 6 weeks. But as I've shown you with the procedure times we have now, if there is a medical need to do it fast, one more procedure of half an hour doesn't matter. We can do it tomorrow. If there is a medical need, we do it tomorrow. There is no problem.
So the second question, give me 1 second. The second question is, do you think that AF burden is a superior endpoint compared to simple freedom of AF episodes? So of course, for AF burden, we would need very consistent follow-up by ECG. So what would you think? Which is more important, that we really know that somebody doesn't have any AF documented, or is it enough that there is relief of symptoms?
Yes, maybe I give my thoughts to these questions. From my point of view, we know that the symptomatic patient is the patient who is profiting from this intervention. And yes, we want to have the patients all get rid of all atrial fibrillation. But I think from my point of view, I don't suggest it as a failure if the patient has a big reduction in AF burden and has a better life. So I think in the future we have to think about more what is a failure. I think we should get rid of symptoms. There is a small portion of patients we have to be very eager to get rid of all AF. These are the tachymyopathic patients, the heart failure patients. But in the standard paroxysmal patient who is highly symptomatic, I think every reduction we can get, and we still should aim to get as much reduction as we could possibly get. We should take this into account to not talk about failure in these patients. But I'm eager to hear Tom's comment to this.
Yes, yeah.
Lucas was first.
I totally agree with you, Lucas. And I think what we have to consider in the future, our monitoring methods will be better. I know we have wearables now. Most of my patients are now having an Apple Watch or something else. You also have, guys, lots of people who are implanted with a loop. So I think we will have more and more patients where we have still some kind of episodes of atrial fibrillation because we will be able to monitor them. But I think the symptoms, so I think the symptoms are that's what count, and I think maybe that will be an endpoint what we should consider in the future. I think that's my opinion on that, especially because of the monitoring methods we're improving over time now.
Yeah, I think it's a really fantastic question. It's one of the most important changes I think we'll see in direction of our assessment of AFib in the near future. And the binary classification of failure or success of ablation with the 30-second recurrence has its historical value. We use it as a definition in clinical trials. We will keep using it for a while because it's a useful way to compare trial outcomes. But for a patient who comes to the outpatient clinic with symptomatic AFib, if you reduce his or her symptom burden with 99%, the patient is going to be happy. There is no discussion about it. And it is clear that AFib burden is important. It's also important for risk assessment. For example, for stroke risk assessment, we are not at all concerned right now with AFib burden, while all the data is pointing us to the fact that the CHA2DS2-VASc is only, well, we should say CHA2DS2-VA now, but is only worth what it is worth. And of course, it's different if you have one AFib episode for 2 minutes in 1 year, or you have AFib every week. Same story for risk of tachycardiomyopathy, for example. Look, for example, at the CASTLE-HTX trial. The outcome of CASTLE-HTX was not driven by the success of ablation. Many patients had AFib recurrence. It didn't matter for their successful control of heart failure symptoms. And I have zero doubt that AFib burden will play a major role in our AFib assessment and consequent management in the near future.
This is actually an interesting point because we didn't hear anything about the oral anticoagulation. I think at least in in our societies for the cardiologists, it's not such a big deal yet to perform anticoagulation after PVI ablation, especially, or sorry, I wanted to say based on the CHETS-VAS score. Are there any issues from your side? Because personally, I'm working for a few years at a heart surgery, and it's quite interesting to see how cardiac surgeons actually are how to say they're not okay with the OAC therapy on the long run, even if patients have a clearly elevated CHETS-VAS score. How do you see that? Any thoughts about it? Or would you say it's quite clear based on the CHETS-VAS score we have to give oral anticoagulation, and this is the actual, how do you say,
I think surgeons have been always very relaxed about this, Christoph. So we see, I think one very important point when we do a successful atrial fibrillation ablation is that we do see sometimes patients who are having recurrences of atrial fibrillation, but for some reason now they're completely asymptomatic. So for these patients who might actually have quite a significant burden of atrial fibrillation, but for some reason they're completely asymptomatic now. So if they have a very high CHETS-VAS score and we're not anticoagulating them, definitely we're putting them in jeopardy of developing like a thromboembolic stroke or a thromboembolic event. So I think we cannot copy what surgeons are doing. I think we should stick with the guidelines and keep anticoagulating these patients with the high CHETS-VAS score.
But I think it's quite important because the difficulty is sometimes that patients get two informations with a completely diametral and they don't know whom to follow. And I think it's very important to, at least that from the cardiologist side, that we are quite clear that we will follow these recommendations based on the CHETS-VAS score. Sorry, Tom.
Are you asking about anticoagulation after successful ablation or potentially successful ablation, or in general?
After ablation, because especially look at especially the situation in MACE ablation is that almost all of these patients got as well LLA resection, or they got the so-called AtriClip now.
So we will. Sorry. Go ahead.
Please, yeah.
Well, I was going to say we will have very, very interesting data today. Today at AHA, the option trial will be presented, which mimics LA exclusion, which is concomitant LA closure at the time of PV isolation. It will be presented in a few hours. And of course, there is also the OCEAN trial, which I don't know when it will be finished. It will take a little bit longer, which studied stopping anticoagulation after successful ablation. But I think you're absolutely right. Until we have that data, at least until we have the option trial data, I think the message should be that the guidelines are quite clear. The high-risk profile patients need anticoagulation for stroke prevention, considering their AF a risk marker, not necessarily a risk factor.
Okay. So, yeah, any more questions from your side? Salim or Omar, maybe?
No question.
Okay. So,
I think yes.
So maybe one question to both of you, because first I think Salim presented mainly the American guidelines, and then Omar, you presented mainly the European guidelines. So you're more or less in between. So what are the more important ones for you?
I looked for both, to be honest with you. I train in North America, so I follow the Canadian and American guideline. But to be honest with you, the European recently is more updated and more. The American is slightly get delayed.
Okay. Good. Please look.
I think we're biased according to the area where we were trained, I think. I was trained in France, then I went to Canada, so I follow the European guidelines mostly. But I do consider the American guidelines. I do look on the American guidelines and the updates from them as well.
Of course, most of the time they're overlapping, but of course there are few discrepancies, and so would have been interested. So what would you prefer, actually? Okay. So I think, Lucas, you had a...
Yeah, I think sometimes the American guidelines are more clear. If you go to the ACC, for example, if they have fast atrial periods in the pacemaker, the Americans are quite clear. They say if over 24 hours you have to anticoagulate, and we have over under 24 hours only to be indication. And in our recently guidelines, we only have like a to be indication on that. And the Americans are also more clear about post-operative atrial fibrillation, which is also kind of diversity, where you see they think like you may think about after 3 months after surgery to to skip the NOAC. We say we have to keep it on. So it's kind of interesting because we're not normally I think we were very close to the Americans, and now we have some diversities which are kind of debatable. So that's really interesting. Also from my side, how well-developed countries with good medicine are challenging the differences sometimes you find.
Yeah, you're right. Yeah. So yeah, I would have a question just to know about the situation in Belgium and the Emirates. So we're starting now in Vienna for a few weeks a program for the hybrid ablation, because we have new recommendations in the European guidelines. And the other question is, so how it is in your countries? Are you already performing it, or will you start such hybrid ablations, especially for the persistent AF?
I think in UAE, I don't think we have any program for hybrid AF until now.
For Belgium, hybrid surgery is certainly existing, and established programs exist in a few centers, as in most of our surrounding countries. The challenges with hybrid surgery are resources. It is expensive in terms of money, human resources, lab time, exposes the patient to significant challenges. So it is not an easy fix, but I completely agree with you that we have deliberately chosen to give surgical approaches, hybrid surgery, and even general surgery approaches. We have chosen to give them a very visible role in the management of persistent AFib in the guidelines because of trial data. The data is undeniable.
Yeah, okay. But you think as well that the number will increase, at least I think in Austria. So we're starting now, and I think that we can perform at the moment on average 1 to 2 per month. So I think that will increase. I think in Belgium it will be increased as well.
I believe so.
Okay. So yeah, see if there's. Yeah, please.
I have maybe a question for the rest of the panel, but if you have a question from the audience, it's always more important.
No, unfortunately not.
Okay, so everybody in the audience, feel free. And meanwhile, I have a question for the panel. I was in a discussion not too long ago with some colleagues from Nordic countries, and we were discussing age restrictions. And I'm wondering if you apply any age cutoff beyond which you maybe, I'm not going to say never, but where you would not typically recommend catheter ablation for your patients. I can answer for Belgium. We do not. If the patient is healthy and has a good life expectancy, there is no specific age cutoff. Of course, an 85-year-old is less likely to receive a first-line recommendation for ablation than a 60-year-old, but there is no cutoff. And I know it is strongly different in the Nordic countries, for example. And I'm wondering about your experiences.
I think you missed the discussion in the beginning because Omar said...
I'm sorry. Yes, I
was
online.
No problem. No problem. No,
late.
No, it's really no problem. But because actually Omar said that age shouldn't be a number, but we should take into consideration how fit a patient is. So we have to take into account if somebody with already in his end of his 60s is already frail, of course he's old. And if somebody is 90 and is running half marathons, so yeah, you may ablate him if he's a symptomatic AF patient. Yeah.
100% agree.
Yeah. So
Yeah.
Thinking also Lucas and Lucas, yes, it's we don't do any, or we don't have any absolute restrictions. Of course, we have to take a look at the patient and decide then whether to ablate him or not.
I mean, the only thing what I have sometimes with higher age, I feel more free to give amiodarone because I know that the side effects, you know, they won't live the side effects. So sometimes I try to put my really old patient like 86, 87 or 85 on amiodarone because I know it's very effective and they won't live till the normally they won't live till the side effects. So sometimes I might consider that.
Well, I think with the newer technologies, I think with pulse field, our threshold is going to be a little bit lowered to take patients into the cath lab. It's a much safer procedure, and it's a much faster procedure. Your left atrial dwelling time has came back significantly lower. So I think with radio frequency, I would be a bit more conservative, but with the pulse field, I think I lowered my threshold significantly to take patient to the lab, even above 80, or we've done like recently an 85 years old. So I wouldn't have done this, I think, with the radio frequency.
Okay. Are there any more questions or comments? Unfortunately, I don't see any more questions from the audience. So maybe one small last question. So what do you think how fast PFA will be the standard? Because we have more or less the same results, perhaps less complications. So how fast will it be the standard? Because personally, I think it will be the standard, but the question is how fast. Any comments on this?
I think,
yes. Thank you.
and I think as the more improvement in technology and showing more successful rate more than 80s, then I think the other will may disappear or will be minimized by that technology.
Yeah, I think I agree with that observation, at least as long as we are talking about first-line ablation for paroxysmal, first-time ablation for paroxysmal or persistent AFib, where PVI is the goal. We're not talking about ATs or other arrhythmias or whatever. I think if we forget about resources and financial constraints, it will overtake other energy sources in 2-3 years maximum.
Yeah, I think it's the biggest challenge currently. I think pricing is a major issue. Like once the prices drop down, I think it would definitely overtake the other systems.
Can I just have a question, because I don't know really how in the Emirates health system is working. So is it like for free, or you have like private insurance, or the patient paying privately? What kind of model do you use?
We have the insurance. So for the local is the government insurance, for the employee, and non-local the private insurance.
Okay.
But the problem is now depending on what type of insurance and your coverage. So it's really sometimes challenging to get an ablation easily from the private insurance.
Ah, okay.
They will not cover it.
Thank you.
So almost 6 o'clock. So if there's any more questions, I thank you very much for the really excellent talks and a very interesting discussion. Yes, thank you very much for organizing this meeting. I think from our side, Lucas and Omar and Salim from the Emirates side. So yeah, it was very interesting experience, and yeah, I hope that we can continue this in the next years.
For sure.
And if there's no more comments,
Definitely, you guys should come to Austria to visit us
like
in the winter and the summer. So I tell you, our conference is really nice in Salzburg. It's always in the end of May, and beautiful weather. The city is UNESCO protected. We have the mountains, and actually, we also have what's really cool is that we have a direct flight from Dubai to Salzburg because we have more and more tourists from the Arabic states. So we're looking forward to see you.
So,
And I hope we will continue this cooperation more and more fruitful, more and more in the future. So and see each other more.
Yeah, for sure.
definitely, yeah.
Thank you, everyone.
Thank you very much, everyone.
and
Thank you very much for the invitation.
for your for the talk as well. Okay, good. So see you next
Thank
time.
you, guys.
See you.
Have a nice
Thank you.
weekend.
Have a
Nice
nice weekend.
weekend.
Bye-bye.